Welcome, everyone, to the Adult Obesity Guidelines webinar series hosted by the Office of Lifelong Learning at the University of Alberta and Obesity Canada. My name is Denise Campbell-Scher, and I'm the Associate Dean for the Office of Lifelong Learning, as well as the family physician here at the University of Alberta. It was my great pleasure to serve on the executive of the Canadian Clinical Practice Guidelines. The new clinical practice guidelines are expansive, 19 chapters on a wide range of topics related to obesity diagnosis and management, weight bias, and more, all written by Canada's top researchers, health practitioners, and patient advisors. They are the first truly patient-centered clinical practice guidelines on obesity and the result of more than 3 years of hard work. Just before we begin, I'd like to go over a few introductory items. We acknowledge that we are on the traditional territories across Canada of the many First Nations, Métis, and Inuit whose footsteps have marked these lands for centuries. If you have technical questions pertaining to the webinar, please use the chat feature at the bottom of your screen. If you have questions for our panelists, please use the question and answer feature of the webinar located at the bottom of your screen. Our panelists will answer several questions following the oral presentation. Some questions will be responded to through text in the Q&A window. You can, at any point, use the Q&A button at the bottom of your screen to submit questions. We anticipate many questions. Please review what has already been asked and upvote those questions you would like to have answered. We cannot guarantee that the panelists will be able to respond to all of your questions. A recording of the webinar will be available next week. It will be sent to you via email for everyone that has registered. This link is for your personal use and is not to be forwarded or shared. This activity has not been formally reviewed by the CFPC or Royal College. However, it is eligible for non-certified credit. Main Pro Plus participants may also earn additional certified credits by completing a linking to learning exercise. Please contribute your experience with obesity management to inform our advocacy and programming. So while you're waiting or after the event, please take 5 minutes to contribute your perspective by scanning this QR code. So it is my very great pleasure to introduce Dr. Arya Sharma, who will be presenting on assessment of adults living with obesity. Dr. Sharma was recruited from the Humboldt University Berlin in 2002 to be a Canada Research Chair, Tier 1, in Cardiovascular Obesity and Management at McMaster University. In 2007, he accepted a position as Professor and Chair of Obesity Research and Management at the University of Alberta, where he is also the Medical Co-Director of Alberta Health Services Provincial Obesity Program. In 2005, he spearheaded the launch of the Canadian Obesity Network, now Obesity Canada, which has remarkably transformed the landscape of obesity research and management in Canada. His research focuses on an evidence-based approach to the management of patients living with obesity and includes the development of the Edmonton Obesity Staging System. So Arya, I will turn it over to you to give us our presentation on assessment of adults living with obesity.
Yeah, thanks for that introduction, Denise, and welcome to everybody who's attending this webinar and those of you who are watching the recorded version. My task today is to go over with you some of the key items about the assessment of adults living with obesity that are described in the new guidelines. Now, this is quite a large chapter. There's a lot of information in this chapter that you'll find interesting. I'm just going to point out some of the highlights of this chapter. So I'm trying to take over the screen over here. There we go. So what I want to focus on and start off with are some of the key recommendations for obesity assessment in adults. I then want to focus on what is really new in terms of these recommendations. And I'm just waiting for the screen to respond here. Perhaps Melanie can help out. And I want to focus with the, and I want to start by focusing on the key recommendations that are evidence-based here. And the first one of these is that we suggest that healthcare providers involved in screening and assessing and managing people living with obesity use what is called the 5 A's framework to initiate the discussion by asking for permission of the patients to talk about their weight and assessing their readiness to initiate treatment. We'll be describing more about what the 5 A's framework actually is later in this presentation. Next slide. Healthcare providers can measure height, weight, and calculate body mass index in all adults, and also measure waist circumference in individuals, which provides some additional information. But as I'll be pointing out, we should not be basing the diagnosis of obesity itself on BMI alone. Next. We do suggest that a comprehensive history to identify root causes of weight gain as well as complications of obesity and potential barriers must be included in each assessment. So it's not enough to just measure body mass index or measure weight, but we do have to try to understand what exactly is driving obesity in this individual so that we may be able to provide help to this individual to stop gaining weight. Next slide. Next. We do recommend that blood pressure measurement is taken in both arms, that fasting glucose or glycated hemoglobin measures are examined, lipid profile, all of that, of course, to characterize cardiometabolic risk. Where appropriate, we also recommend that ALT is used to screen for non-alcoholic fatty liver disease. Next. And we do suggest that providers consider using the Edmonton Obesity Staging System to determine the severity of obesity, and that this will help guide clinical decision-making. So those are the key recommendations in the guidelines. And I'll now take each one of these and provide a little bit more background and detail. So I want to start with the definition of and screening for obesity. So as all of you know, the previous definitions of obesity have always been based on body mass index, which, as you know, is a number that you calculate based on people's heights and weight. What we've come to realize is that while body mass index is a good measure of body size, it's actually not a very good measure of of actual health. So while BMI tells you how big someone is, it doesn't necessarily tell you how sick someone is. And of course, when we're dealing with patients in our practice, we need to make decisions about that patient or for that patient or with that patient based on their actual health status. And so what is really new in these guidelines is that we are moving to a much more functional definition of obesity, where we define obesity as a chronic, progressive, relapsing disease that is characterized by the presence of abnormal and excess adiposity that impairs health and social well-being. Now, the key word here is impairs, which basically means that if you don't actually have a health impairment from your size or from your weight, well, then you don't really meet the clinical criteria for obesity. And that is a departure from the old BMI based definition, where you could just calculate someone's BMI and look it up on a table and decide whether someone has obesity or not. Today, based on this definition, you can only diagnose obesity in someone after you have completed a full medical exam, taken a full medical history, and run all of the tests that are necessary to determine whether or not a person's health is actually being affected by their body weight. Some of you might previously have heard the term healthy obesity, which refers to people who meet the BMI criteria for obesity but are otherwise healthy. Well, that term is now obsolete because by definition, if you're healthy, you don't have obesity, irrespective of what your BMI level may be. This recommendation is actually very much in line with Health Canada's recommendation that the diagnosis of obesity be not based on body mass index alone. Next. Now, this does not mean that body mass index is useless. Body mass index certainly plays a role in population surveillance studies. So if you want to know whether obesity is increasing across Canada, when the BMI number for Canadians goes up, we know that there's probably more people in Canada living with obesity. We also know that there are other indicators that can be measured, such as waist circumference, which characterizes people in terms of the presence of visceral fat. And we know that visceral fat, again, is a risk factor for obesity-related health issues. And so there are certainly people who would benefit from a body mass index calculation or a waist circumference measurement in terms of risk identification. Next slide. And this is why when you screen people for obesity, there certainly is a role for regular assessment of body mass index and waist circumference, and also measuring other cardiovascular risk factors, because these will help you identify those individuals who are perhaps at greatest risk of developing obesity or may already have obesity based on the fact that they already have health impairments because of their weight or size. Next slide. Now, it's important to remember that for most populations, while the presence of overweight is generally considered to be at the BMI of 25, and that's when you should probably start screening people for the presence of health impairments. We have to remember, next one, that, next slide, that in adults with Southeast or with South Asian or Southeast Asian or East Asian ethnicity, the recommended body mass index cutoffs for overweight are much lower. These individuals from these populations seem to be much more susceptible to obesity-related health issues, and you might want to start screening people for obesity if they are from this ethnic background at a much lower body mass index level. We also have to remember that in special populations such as the elderly, muscular patients during pregnancy, people who are extremely tall, people who are very short, the body mass index can be quite misleading and therefore needs to be interpreted with caution, which is why you probably need to use good clinical judgment when you decide whether or not somebody needs to be screened for the presence of obesity. So I now want to switch gears and talk about the general approach to someone living with obesity. Now, we do know that obesity and weight is quite a sensitive topic. And so the first point that we need to consider here is that healthcare providers should really consider their own biases and attitudes towards people living with obesity. We've known from previous research that many health providers, and this includes doctors, nurses, dietitians, psychologists, all of us who work in the healthcare setting, we are not immune to biases. We carry the same biases that are found in the general population. And as you probably know, there is a general negative bias about people living with obesity. There's a lot of research showing that many of us consider people living with obesity to be not so smart, not so motivated, not caring about their health, less likely to follow medical advice, less likely to adhere to certain treatments. And while we know that virtually none of that is true, these are very widely held beliefs. And it's very easy to see how having these kind of negative beliefs or negative attitudes about patients, can really be a big barrier in how we approach patients and how we try to build a therapeutic relationship with these patients and how we address, how we help patients address these issues. So one of the first things that we recommend is that we become explicitly aware of the fact that we ourselves might be harboring these biases, and we have to make sure that these biases are not affecting our approach to patients. A general rule is that we should try to approach all patients, and this of course includes patients living with obesity, with empathy and sensitivity, and that we also acknowledge the complexity of the disease. I mean, as all of you know by now, obesity is a very complex disease. It's not as simple as saying that someone is eating too much or not moving enough. We know that there are biological factors, there's genetic factors, there's a lot of environmental factors, social determinants of health. Many of these factors are not under control of the individual. So while the individual, of course, can be motivated and can try to do the best they can with the genetics that they're given and with the environment that they're living in, and do have some control over their environment, we have to acknowledge that many of the drivers of obesity are not really within the control of the individual. We also have to understand that because of the way that bodies work, where they tend to defend their body weight, there are no simple solutions to obesity. So even in your most highly motivated patient, if that patient tries to lose weight, chances are that the weight sooner or later is going to come back, and that is just normal biology. Biology dictates that when people try to lose weight, the body is going to respond to that weight loss by making it much easier for the patient to gain the weight again. And this, of course, makes any treatment for obesity complicated. And so pretending that there's a simple solution for obesity, just eat less, just move more, those are not really helping to set up a therapeutic relationship, because to be honest, most patients have already tried those simplistic approaches and have found them not to work. And so we as health professionals go in and tell them, well, all you have to do is eat less and move more. Well, that is not a very convincing way to build up a therapeutic partnership with patients, because really those are not things that are known to work or actually turn out to be effective. Next. So it is upon us to create a supportive environment. We have to make sure we have the appropriate equipment, which includes proper sized blood pressure cuffs, proper sized gowns. It's good to have armless chairs in the waiting room so patients can sit down. And what's also quite important is that we do any weighing of patients in a private setting. We don't comment on the weight, and we try to make sure that the patient, has also agreed and consented to being weighed. Next. It is always a good idea to start off this entire encounter ultimately by asking for permission to weigh patients, because this is something that shows respect to the patient. It shows our empathy. It shows that we understand that this is a sensitive topic for many patients. And so it ultimately helps foster patient comfort and dignity. Now, I previously mentioned in the recommendations that we should be using a 5 A's approach to obesity management. Now, the 5 A's approach is a structured interview format which has been adapted by Obesity Canada specifically for facilitating discussions about obesity in primary care. For those of you who are not familiar with the 5 A's, here's just a quick reminder. We start by asking for permission to discuss weight and explore readiness for change. You then assess the patient in terms of obesity-related risks and try to identify the root causes of obesity. You would then advise the patient based on your findings about their health risks, and you would discuss treatment options with the patient. You would then come to an agreement with the patient on what the actual health outcomes and behavioral goals are that you would like to see in the patient. Remembering here that weight loss itself is actually not a behavioral goal, because weight loss is not a behavior. When you focus on behavioral goals, you need to focus on things that patients can actually do. And this may include, keeping a food journal, or, taking your medication, or whatever the behavior is. It has to be something the patient can do. Weight loss is not a behavior. Weight loss is something that may or may not happen based on a behavior. So you don't make weight loss a goal of treatment. And ultimately, you assist the patient in accessing the appropriate resources and providers. And assisting also means that you arrange follow-up to see the patient again, because as you remember, obesity is a chronic disease, and this requires an ongoing management, an ongoing relationship with the patient. So it's not something where you discharge a patient from your practice once they've lost weight. This is really part of an ongoing process. So I now want to talk about assessing the drivers and health impacts of obesity. One of the frameworks that seems to be quite useful in addressing the search for barriers, drivers, and also the health consequences of obesity is what is called the 4 M's approach. Now, the 4 M's stand for the following. The first M stands for mental health. And we've recognized by now that mental health is such an important part of any obesity assessment and management program. This starts by assessing the knowledge and cognitive ability of a patient. We have to examine the expectations that a patient might have. A lot of patients struggling with self-image. We have the whole issue of internalized weight bias, which you've already heard about in previous seminars. But we also have to acknowledge that many people living with obesity struggle with with formal medical diagnoses that may include mood and anxiety disorders, attention deficit disorders, addictions, eating disorders, sleep, personality disorders. All of these factors can promote weight gain. They can be barriers to weight management, and they can sometimes even be consequences of weight gain. For example, self-image issues can be a direct consequence of someone carrying excess weight. So it's really important to start by doing a mental health assessment. We then have the second group of problems, and these are described as mechanical issues that largely result from the excess body fat and the excess weight that the patient is carrying. So here you would include issues like osteoarthritis, sleep apnea, plantar fasciitis, reflux disease, urinary incontinence, intertrigo, etc. So there's a long list of these more mechanical consequences of living in a large body. And again, all of these can be directly consequences of obesity. They can sometimes contribute to weight gain. So if you're thinking of a patient with osteoarthritis who has pain, if you're thinking of someone with sleep apnea who doesn't have the energy to be active, these are all factors that can certainly contribute to weight gain. And in most cases, these factors can be significant barriers to obesity treatment. We then have the third M, which is a long list of metabolic consequences of obesity. So we have diabetes, dyslipidemia, hypertension, gout, fatty liver disease, heart disease, issues around infertility, polycystic ovary syndrome, cancer. All of these factors, again, can be contributors to weight gain. For example, if you think of someone who has type 2 diabetes, who is on medication for type 2 diabetes, that could cause weight gain. When you think of people who have heart disease, who are less able to be physically active, etc. These are all factors that can contribute to weight gain. We know that all of these factors can result from excess weight gain, and sometimes many of these factors can also be barriers to weight management. So when people have these underlying diseases where they have to take medications, for example, that promote weight gain, it might be very difficult to manage obesity in some of those patients. And again, this is something we need to acknowledge to the patient, and these are certainly patients who are going to require even more of our support. And the fourth M finally refers to milieu, and here we're talking about all of the social determinants of health, socioeconomic status, education, occupation, access to food, food insecurity, disability, whether patients have access to treatments like obesity medications, whether they have access to bariatric surgery, for example, whether they have access to a psychologist. Those are all factors that can certainly prove challenging in patients. And sometimes be real important barriers to treatment. So once again, if you remember the 4 M's, and remember that we have mental health issues, mechanical issues, metabolic issues, and milieu issues, you can actually, know that this is a wide range of information that you need to gather from your patient before you can actually make a proper assessment of what the drivers of obesity are, what the consequences of obesity are, and what the barriers to treatment for that individual might be. Now, many of you, when you look at this list, are probably thinking, I don't actually have time for any of this in my clinical practice because I have a busy clinical practice, and I don't have time to cover all this information. Now, that might certainly be true if you're a specialist, but if you were the family doctor for this patient, I would assume that most of this information is already in your charts. If you know this patient and you've been working with this patient for many years, you should already have, I would say, 90% of this information in your charts and know all of this information about your patient. So this is not actually an extra burden in terms of assessment. What is different is that you have to bring these other conditions or these other problems that the patient has and that you already know the patient has, and set them in relationship to what that actually means for obesity management. So for example, if you have a patient who has depression, they're already on treatment for depression, they've had depression for many years, and now they're experiencing weight gain, you have to think about whether or not that depression or the treatment for their depression may in fact be one of the drivers of weight gain. And so it's not about gathering new information about the patient. It's really about putting the information that you already have about your patient and what you know about your patient into the context of obesity management, and decide whether these factors may be driving weight gain, whether some of these factors may be consequences of their excess weight, and whether or not any of these factors are actual barriers to obesity management. So again, if you take depression as an example, if you have a patient who's gaining weight, maybe because of their depression, but depression is not really being well managed in this patient, well, then it's going to be very difficult to get good obesity management in that patient, unless and until their depression is addressed. And that same would hold true, for example, for a patient with unmanaged osteoarthritis, or a patient with sleep apnea, or a patient with any of these other issues, which, if not managed, are going to make it really difficult for this patient to manage their weight. Next slide. Now, obviously, everything starts with a history, and so here are just a couple of comments on the type of things that you're looking for in a obesity-centered history. Obviously, this would include all of the things that you would normally include in a medical history. So past surgical history. You want to know what medications they're on, whereby you're specifically looking for medications that might be promoting weight gain, or medications that might make it much more difficult for patients to lose weight. You're of course interested in allergies. You're of course interested in social and family history. So really, this is not very different for a patient with obesity than for any other kind of patient, where it's important to have this information. Next. Now, as I've already mentioned, one of the key things that you want to be looking out in your history are what do you think are the underlying root causes, and what are the consequences of obesity? Now, sometimes root causes can be found in the history of a patient. So if a patient tells you that they did not have a weight problem till 6 years ago when they had a motor vehicle accident where they were rear-ended, and now they have problem with their neck, they have problem with their back, they have problem sleeping, and that's when they started gaining weight. Well, then it's much easier to understand what's happening in that patient. So you have to kind of look at life events and things that may have happened to patients in the past that could have ultimately resulted in weight gain. And sometimes these events might go back to early childhood. You might have people who've had a history of sexual abuse, physical abuse, other forms of emotional trauma that could eventually have ultimately set them off on a path of weight gain. You have patients who have PTSD, you have patients who have binge eating disorder. So you have to kind of, be sensitive for picking up that kind of information in your history. Next. Obviously, there are things that you can screen for by asking questions, by using standardized questionnaires. So when we talk about sleep disorders, physical, sexual, psychological abuse, eating patterns, physical activity, internalized weight bias, obesogenic medications. I mean, this should all be part of standard assessment for any patient, and specifically for a patient with obesity, because it's vital to have this information in order to understand why this patient has obesity. It's not enough to say this patient has obesity because they simply eat too much, or they don't exercise enough. That's like saying someone with depression is not happy, has depression because they're not happy. You're describing a state, but you're not explaining the state. So what you really want to understand is, why is someone eating too much? What are the drivers? What are the potential, root causes of that weight gain? Next. So we've got, identifying and documenting patients' values and goals around treatment and fostering insight, of course, is all part of the information that you try to gather from the history. Next slide. Similarly, in a physical exam, and we can go through this quite quickly, is you, of course, want to take anthropometric measures, height, weight, body mass index. I've already spoken about that. Blood pressure should be measured. Make sure you have an appropriate cuff. Neck circumference, airway patency, because that will tell you something about the risk of sleep apnea. Routine cardiorespiratory, head, neck, gastrointestinal, joint, gait, skin exam. All of those should be part and parcel of an exam for obesity, because again, it gives you insights into some of the problems that the patient has. A cursory endocrine exam, including palpating the thyroid gland, screening for Cushing, PCOS. All of this stuff should be part of a routine assessment when indicated or as appropriate for individuals. When it comes to the actual health risks, and again, we can do a rapid build on this slide. There is no single blood test or diagnostic evaluation that's indicated for all patients. You have to use your judgment. There are certain issues that are more common. Next. You would base your decision on what to test for really based on the presenting symptoms of the patient, and what do you think the patient's risk factors are, and what's your index of suspicion. You would certainly not be testing all patients for everything. That's not an efficient use of anyone's time. So you need to use your clinical antenna to decide which are the tests that you want to run in certain patients. Now, obviously, there are some issues that are quite common. We're thinking metabolic syndrome, so it's probably a good idea that most patients at some point get tested for fasting blood sugars, HbA1cs, cholesterol, triglycerides, etc. Next. And of course, we also know that many of these patients could be at high risk for fatty liver disease, and so screening for elevated ALT levels, and perhaps if they're elevated, also ordering an abdominal ultrasound is probably a good idea. Again, not for all patients, but using good clinical judgment, you decide who the patients are who need to be examined for these problems. Next. In terms of cardiac diagnostics, again, we know that coronary artery disease, other problems related to cardiac diseases, everything from atrial fibrillation to ultimately congestive heart failure is quite common in individuals with obesity. We have to be aware that there are certain limitations for the routine tests that we use. So, for example, for an ECG, there are certain limitations that may lead to a wrong interpretation. Next, there are limitations with exercise stress testing. Next. There are limitations with stress echocardiography. Although, if you have a good operator, if you have a good person who's conducting this test, this should really be possible in most scenarios, even in quite large patients. It shouldn't be a barrier, but it should just be something that probably needs a bit more attention. Ultimately, of course, the best the best imaging techniques are SPECT, and the next one is PET. These are more sophisticated measurements. They have very high specificity and sensitivity, but they may not be available in every patient. And again, this is not something you would do on every patient with obesity. These are tests that would be reserved for patients who you believe may have coronary artery disease or certainly have a lot of risk for coronary artery disease. Next. Now, we've already mentioned the Edmonton Obesity Staging System. Those of you who are not familiar with the system, this is a system where you can range patients from stage 0 to stage 4, depending on the presence or not of obesity-related health issues. As you can see on the panel, on the right-hand panel, what you see there are survival curves based on body mass index. And as you can see, the body mass index is really not a very good measure to differentiate long-term mortality risk in individuals. As you can see on the lower panel, the Edmonton Obesity Staging System does a much better job of distinguishing people who are at high risk for increased mortality and those who are not. So if you look at the blue line there, for example, that's the lower line. That's people with EOS stage 3, and you can see that those are the individuals who have a much higher risk. The next slide just gives you a quick reminder of what the EOS stages are. So stage 0 are individuals who meet BMI criteria for obesity, but really don't have any other obesity risk related risk issues. Now, given that we have redefined obesity as actually requiring that people have certain impacts on the health, we could argue that there no longer needs to be a stage 0, because if you have stage 0 obesity, you really don't have obesity, you just happen to be a large person. Stage 1, however, means that patients already have subclinical risk factors, pre-diabetes, pre-hypertension, for example. Stage 2 would be individuals who have an established obesity-related chronic disease. Stage 3 would be individuals who have end organ damage or very significant psychopathology or significant functional limitations. And stage 4 ultimately is what you might call end-stage obesity. These are individuals who have severe disabilities from obesity-related health issues. And so scoring this system, should be part of routine clinical assessment. Next. So to summarize the key messages from the guidelines, the first one is that obesity is a chronic, progressive, and relapsing disease, which is characterized by the presence of abnormal or excess adiposity that impairs health and social well-being. So we are no longer using a BMI definition of obesity, but we're using a much more functional definition to make sure that people that we label with the term obesity are in fact people who have a disease, are in fact people whose health is being impacted. Next. Screening for obesity, can be performed by regularly measuring people's body mass index and waist circumference. You have to be cautious about this when you take people's weight. You have to explain why you're doing it, and remember that simply having an elevated BMI is not diagnostic of obesity, but is certainly something that should prompt more tests, more examinations to make sure that this actually is a person who has a health impairment because of their size. Next. The clinical assessment of obesity should aim to establish the diagnosis and identify the causes and consequences of abnormal or excess adiposity. And this, of course, includes doing a physical exam, mental exam, functional exam, all of the kind of exams that we've just talked about and that you would probably want to do in most patients anyway. Next slide. Providers who are participating in the assessment of obesity should focus on establishing values and goals of treatment. And as I mentioned before, weight loss is not really a goal of treatment. When we think about goal of treatment, the focus should be on improving health. And we can get a lot of improvement in patients' health. Someone who eats better, is more active, feels better about themselves, is going to experience an improvement in health, even with very little weight loss. So the focus of obesity management should not just be about how do I get a patient to lose weight. It should really be much more holistic in terms of thinking of how can I help this patient be healthier and reduce, reduce the risk for future disease and just help them live healthier lives. Next slide. And all of this needs to be facilitated in a non-judgmental, stigma-free environment, because otherwise it's going to be impossible to really build a constructive, positive relationship to your patient. And so the attitude with which you approach the patient, and this brings us back to the initial issue that you need to be aware of your own biases and your own ideas and negative stereotypes that you might have about people living with obesity. You want to, examine those and be aware of them so that you can actually build a non-judgmental, positive relationship with your patient. Next slide. So that brings me to the end of this presentation. This was a very quick summary of the guideline chapter. The guideline chapter, which you can download from the Obesity Canada website, is much more. There's a lot more detail there in terms of some of the things that I've mentioned, and so you're free to assess those. I also want to just remind you of the little QR code that you saw before the start of the seminar, and I'm sure we'll put that back on as we go into the Q&A session. I recommend that you use that, share with us perhaps a small story about someone that you've recently seen with obesity, and answer the questions. And I think this is going to be an interesting exercise, not only for yourself, but it's certainly going to provide us with a lot more data that we will need as we go about, further, defining the best mode of practice for patients living with obesity. So thank you so much for your attention, and over to you, Denise, for the Q&A session.
Thank you, Arya. Yeah. So on the panel today for the Q&A, in addition to Dr. Sharma and myself, we have Dr. Megha Potter and Dr. Paul Poirier. Dr. Potter is an endocrinologist and obesity medicine specialist in the Toronto area. She has completed an additional fellowship in both medical and surgical treatments of obesity at McMaster University, and was certified by the American Board of Obesity Medicine in 2016. She currently practices as an endocrinologist with the LMC Endocrinology and Diabetes Group, where she runs an outpatient weight management program. Additionally, she also manages a community-based pre- and post-operative bariatric surgery program at the Wharton Medical Clinic in Stony Creek, Ontario. Dr. Poirier received his bachelor's degree in physical activity sciences and his master's degree in experimental medicine, studying the role of exercise training in type 2 diabetes. He then went to medical school and obtained his MD degree in 1992 from Laval University, where he subsequently completed training in internal medicine and cardiology, as well as a PhD in experimental medicine, studying the role of exercise in diabetes and the impact of diabetes on exercise capacity. He pursued postdoctoral studies at the University of Colorado Health Center in Denver and the endocrine division under the guidance of Dr. Robert Eckel, and is a professor in the Faculty of Pharmacy at Laval University. He's also been the chair of the Obesity Committee on the Council of Nutrition, Physical Activity, and Metabolism of the American Heart Association. So thank you so much to Paul and Megha and Arya for joining us on this Q&A. And we have a number of questions. And I think Tio actually launched into this first. So, and he was asking about EOS stage 0 and whether it will be of benefit if we put the patient into a pre-obesity stage. It may, and what is it? What are the clinical implications of that? How should we be monitoring patients who are in that stage? So does anyone want to kick us off with an answer to Tio's question?
Well, I can start. I mean, as I mentioned, if by definition obesity only applies to someone who has health issues, then really there is no stage 0 of obesity. And so the term that you're suggesting, referring to people with stage 0 as having pre-obesity is certainly something one can consider. Again, being aware that not everybody who's a stage 0 is eventually going to progress, right? So just because someone has stage 0 or just because someone lives in a large body does not mean that they are at some point going to develop health issues. And even if they do, it might be a very long time till that actually happens. So yes, you could describe it as pre-obesity, but I would probably just say that if you have an individual who's otherwise healthy, that you would just regularly screen that individual to make sure they're not actually progressing to someone who has obesity. We'll have to see how that works out in clinical practice, but you raise an important question. It's an important point to consider.
Mm-hmm. If I may add, it's Paul here. If I may add, if you look at the literature on healthy obese, those people are usually younger without health issue or with health issue that have not been unmasked by the 5 A's or the 4M. So the thing is, healthy obesity is sometimes very misleading. And if you follow those patients long enough, they will die more compared to lower BMI type of patient. So I think it's a misnomer here.
Mm-hmm. Yeah, no, certainly a very important issue. And I guess, Teo, just from a primary care perspective, I would chime um, in the sense that it's always important that we maintain a surveillance as to how people are in terms of weight stability. So if when someone's been weight stable for 10 years since the birth of their fourth child, they're incredibly active, they're engaging in a good lifestyle, and they're weight stable and they don't have any physical or metabolic factors, then that's fantastic. One of the things with these guidelines we're trying to move the needle on is that we actually want all Canadians to be exercising and eating really healthy diets, irrespective of what their BMI is. So those good, healthy messaging around just general excellence in terms of taking care of yourself, getting enough sleep, et cetera, managing stress, all those things are really important for everybody. So not just for people who happen to have a higher BMI. So there is an opportunity to make sure that we're surveying people, that they're weight stable, that they're doing well. And then as Paul says, perhaps a little bit of an extra eye on people who may happen to have a larger body to make sure they're not developing these comorbidities. Again, as Arya said, you know, if you have a patient from Southeast Asia who has a BMI of 26, but is having metabolic syndrome, we would say that that person has obesity. So again, they don't have an EOS 0 either. So it's just shifting the needle a little bit away from just BMI. Megha, do you have any thoughts on that?
Yeah, I mean, I completely agree. I think that the emphasis has been so much on weight in the past and BMI, and we are really trying to move away from it. But I agree with you completely in that trending weight is, there is probably still some relevance in doing that, especially in our patients who don't necessarily have obesity right now, but could be at risk of it in the future. So I do think it is part of the assessment. I think we need to move away from it being the sole diagnostic feature and the sole goal of treatment, but it certainly still plays a role in terms of how we're approaching patients and looking at overall risk factors.
Mm-hmm. And I think we've answered Carol's question as well, because she had a question about healthy obesity. And if we consider assessment, just as we're carrying on in this thread, Virginia and Rena had some related questions. And what Rena is asking is that if the goal is long-term success, what are the ways of measuring this that don't involve ongoing extensive medical assessments? And so it's sort of a little bit of a primary care flavor to that question, which is obviously where most of this management will happen. And Virginia is asking about interdisciplinary team. And so does anyone have any thoughts about those elements?
Well, it's Arya. Again, I can take this question. I mean, obviously, if you have an interdisciplinary team, that's going to make assessment a lot easier. You know, a lot of the initial assessments can be done by a physician assistant. A lot of the detailed history, say the diet history, which I haven't gone into detail here, the weight history, again, I haven't gone into detail here. Some of the psychological issues. I mean, those detailed histories are best taken by people, you know, who come from those fields. So if you have access to those individuals in your practice, then definitely, I mean, you want to make sure you have all those resources and all those individuals involved. But you know, but if you're on your own and you don't have access to a multi-component team, well, then I still think that you can probably get most of the information that you need in order to, you know, manage the patient. But by all means, I mean, if you have a team, use the team. This is a very complicated issue, and patients can use all the support they can get.
Mm-hmm. Absolutely. And I'd like to add, thank you for really asking, you know, what is the goal of long-term success? Because I think that was a really important conversation that we had when making the guidelines is how do we really understand what success looks like if we're trying to move away from solely weight-based goals. And so I think an important approach to patient-centered obesity care is really understanding, you know, what are the patient's goals themselves. And that's why the 5 A's are so important. You know, the patient's goals could be very functional. They could be, I want to be able to bend down and tie my shoe or be able to pick up my child. And that really has nothing to do with what their A1C is, what their weight is, or, you know, looking at specific medical assessments, but we're actually looking at, you know, what is the patient trying to achieve to improve their quality and quantity of life? and how can we help them achieve those goals through behavior change. So when I look at sort of what is the long-term success, it's what are the patient's goals, and are we getting them a step closer to achieving them?
Yeah, excellent. Okay, so thank you so much, Virginia and Rena, for those great questions. And I think it's related to Veronica's question as well, when she's talking about, you know, who should be doing this work. And I just think, to echo what was just said, the practical lived reality for many people working in family medicine in Canada, particularly in geographically dispersed places, but even in urban settings, is that we don't always enjoy the privilege and pleasure of having interdisciplinary teams. And so one of the things we're really mindful of with these guidelines is to not make those people feel like they were completely then unable to help patients. So obviously it's wonderful if we do have that access to that support, but it's not always the case. So pretty much, you know, EOS and the root cause assessment done by a caring health provider who's involved with the patient is crucial, and it can be done by anybody who's involved in a therapeutic relationship with the patient. It can be done by dietitians, it can be done by chronic disease nurses, it can be done by mental health workers, it can be done by physicians, etc. So everyone can do that. And in fact, in the 5A's team program, we actually did just that with interdisciplinary providers, and all the resources are there on the Obesity Canada webpage for key messages, because perhaps if you're doing a root cause assessment and you're a dietitian, you may not feel comfortable talking to someone about their urinary incontinence, and they may wonder why they're having that conversation with you. So there's a tool that's actually on there that was created by allied health professionals with key messages about why they might be mentioning some of these things to patients, and making sure that people get a warm handoff to the team member who might be best able to help them with that concern. So it's definitely a team sport. Okay, so Virginia has a question about some of the more obesogenic medications. That was definitely something that came up a lot in the guidelines. Does anyone want to tackle that question?
So Megan, why don't you take this one?
Sure, yeah. So, you know, there's actually a great summary table in the full guidelines in the PDF version and table 8 that gives you an idea of the different classes of medications, what their tendency to promote weight gain is, and alternative therapies, which I think are super helpful, especially from a primary care perspective. But certainly I would say, you know, the top 3 that come to my mind are in the type 2 diabetes management world, certainly insulin and sulfonylureas, just given the high rate of type 2 diabetes in patients with obesity. These are medications that we see very commonly prescribed just because of the patient population and the common use of these medications. And we certainly have a lot of newer pharmacotherapy options like GLP-1 analogs and SGLT2 inhibitors that are actually weight-losing agents. So they are great alternative therapies and sort of a quick and easy thing that we can really help in terms of reducing weight-promoting agents in type 2 diabetes. And then I would say second to that is probably in terms of mental health medications, antipsychotics and antidepressants, specifically TCAs and some of the SSRIs. Those are ones we commonly see as well. Now, they're a little bit more challenging, I can imagine, because patients do respond well to certain psychiatric medications versus others. And there are many situations where patients are sort of stuck with these medications because therapeutically, from a mental health perspective, those are the only ones that are effective and work. However, if we can use alternatives, you know, the suggestion is think about it perhaps before prescribing. If we can try medications that are weight neutral for mental health over other ones, then that would be preferable. And then lastly, not as common, but certainly corticosteroids are something that we tend to see quite a bit, especially in patients with rheumatoid arthritis or other sort of inflammatory diseases that end up being on low dose steroids or sort of slow tapers. That's certainly something that we see correlates quite a bit.
Mm-hmm. Thank you so much, Mega. So Virginia, this is such an important question, and I really do think that that's something that's a real paradigm shift with these guidelines, is that a lot of times when we prescribe in primary care, we don't always think about which medications are more obesogenic. And again, guidance for people about what to do if you are having to therapeutically try a patient on one that is more potentially more obesogenic. And one of those is to talk to people about that side effect and encourage them to weigh themselves regularly, and to let you know early if there's actually an untoward impact on weight. So just like everything else that we manage in side effects, just to have people be aware, and that can help a lot. Does anyone else have any other comments about some of the practicalities of that? No? Okay, thanks Virginia for that. So we should pivot here to Veronique's question. And she's talking about NAFLD, so non-alcoholic fatty liver disease, and what to do when people are getting into ectopic cells, fatty cells in the liver that are toxic and causing increases in ALT. Does anyone want to chime in on that one?
So again, Megan, you might want to take this one too.
Yeah, sure. So it's a great question because it's certainly something that we're seeing more and more often in the paradigm of metabolic syndrome and insulin resistance. Non-alcoholic fatty liver is now the most common cause of cirrhosis in the developing world. So thank you for asking that question. The way I would sort of approach non-alcoholic fatty liver disease is, again, it's a spectrum starting with sort of inflammation, fibrosis, and cirrhosis. And what we really want to try and do is identify patients before they hit the fibrosis stage in terms of, you know, sort of reversibility and preventing them to progress to actual cirrhosis, which is why liver enzyme tests tend to be the first marker suggested. If there is elevation in ALT and AST, then it's a sign that at least we know that inflammation is perhaps present in that patient. So, you know, there are different sort of algorithms and guidelines that you'll see in the gastroenterology world for how to approach non-alcoholic fatty liver disease, but we tend to use the liver function test as a screening. If we're seeing levels that are 2 to 3 times the upper limit of normal, then we move on to imaging studies like an abdominal ultrasound or doing an elastography test to actually see the stage of fibrosis. There are lots of other sort of calculations that you can do. The FIB-4 calculation is probably the most common. But ultimately, in order to truly diagnose the stage of non-alcoholic fatty liver disease, you actually still need to do a biopsy. So my suggestion tends to be, you know, do the screening test for the liver enzymes for patients who have high metabolic risk, insulin resistance, or high risk of metabolic syndrome, and then proceed forward if you're worried or if there is 2 to 3 times the upper limit of normal elevation in liver enzymes. But the treatment modalities, there's still no sort of pharmacotherapy or approved treatment modality yet for patients with non-alcoholic fatty liver disease. It's still recommended to improve lifestyle, reduce weight by 5 to 10%. A lot of agents that are used in weight management, like GLP-1s, have been shown to improve fatty liver disease, but the data and the randomized control trials are still sort of underway to show their efficacy. So it's certainly something that I think should be identified. I would use our GI colleagues if you're concerned about a patient, and then sort of proceed from there.
Mm-hmm. Thanks very much, Mega. So M. Clark has a question about pharmacotherapy in the guidelines. And so mainly getting into this business of coverage. So, you know, in the guidelines, of course, we have to stick with the evidence. And so we have evidence for a couple of medications, which we can comment on. Using off-label medications is something that we can't recommend in the clinical practice guideline. But maybe, Arya, you might want to direct the colleagues to the Timed Right community, where we can have some of those practical clinical conversations. Oh, are you on mute?
Pardon, were you addressing me?
Yeah, I was. We were talking about the timed right community and places where people can have some of the practical clinical conversations that aren't really in the right place in a clinical practice guideline, where we have to stick with evidence.
Yeah, absolutely. So Obesity Canada has created the Time Right community, which you can access to as a health professional. And there's already about 500 or 600 people who've joined it since the launch of the guidelines. You'll find the links there. I think they'll be on the on the slide kit here, but it's very easy to find. If you go to the Obesity Canada website, you'll find a direct link to Obesity Connect. There's actually two platforms. One is called Obesity Connect Pro, which is for the professionals, for health professionals. And then there's also an OC Connect, which is a patient support website. So if you have patients in your practice who you think would benefit from some of this information, you might want to direct them to the OC Connect platform. So these are the two platforms. We've got OC Connect and OC Connect Pro.
Perfect, thanks, Arya. And in the chat box, Nicole has just shared with everyone those links. The other thing to highlight, I think, is that's quite unique about these guidelines is that they are a living document. So there's a ton of research ongoing, and as that research comes to fruition and there's more information to share, then those guidelines will be reviewed on a regular basis and the recommendations updated. So certainly clinically people do use things off-label, but in a clinical practice guideline, we can't recommend that. So Marie has been very patient. She had a question about self-image being mentioned in the 4 M's. And she's wondering about tools or tips that healthcare professionals who are not psychologists could use to help patients improve their self-image and perhaps address some of that internalized weight bias.
Yeah, I can take some. This is where really help from a psychologist can help, because it's not just self-image. There's also sometimes there's a lot of all or none thinking. There's a lot of internalized weight bias where patients are so used to hearing comments about their weight and that they really blame themselves for it. And we know that internalized weight bias can be a huge barrier to people seeking treatment, because a lot of people look at, for example, even just reaching out for professional help as something that they shouldn't be doing. They should probably be doing this on their own. So the idea is I've done this to myself and I should be able to solve it by myself. There's also a lot of internalized weight bias can also lead to the fact that people don't want to accept evidence-based treatments. So for many people, taking medication, for example, or having bariatric surgery is considered cheating. There's a shame and stigma attached to actually getting those treatments. And so this goes well beyond just self-image or identity. And this is really where having a good conversation with the patient, but also the help from a psychologist, for example, who's trained in some of those techniques, would really be helpful.
For sure. And when that's not possible, as it often isn't in the primary care setting, it's one of the reasons why the first A of the ask is so important in setting up a really respectful therapeutic relationship. Even without the access to a psychologist, you can still do a lot of valuable work in this space by really getting into a respectful, supportive relationship with the person and helping them come to see that some of these things are hindering their progress. And this is related to Veronique's question as well, and the statement that Mega had made earlier, which was so important, which is focusing on functional goals. So what is the thing that really matters to the person in their life and health? It's much more motivating for the person to be able to say, you know what, I was able to walk around the zoo last weekend with my grandchildren and I didn't have to sit down, than to say, yes, I did 151 minutes of exercise last week. So really focusing on that is a really motivating and practical approach to be able to help motivate people to continue the hard work of doing some of these efforts. And so there's just go ahead.
If I can just jump in there. So there's there's a term that's used often within the obesity patient community, and that's called the non-scale victories, NSVs. So a lot of patients, when they start out and we tell them what is your goal, will start out by actually telling us a number. So very often they'll say, well, my goal is to go back to or to go down to 180 pounds or 140 pounds or whatever it is. And these are made up numbers. And so very often, one of the first things you want to do when you discuss goals is try to get the patient away from a weight goal and try to get them away from those numbers. Now that's very, very challenging because most patients carry some kind of number in their minds where they would like to get to. Some patients have in fact been told that there's a number where they need to get to. And just one example, a patient who's been told by an orthopedic surgeon that they need to lose 60 pounds. And so now they have that number of 60 pounds in their head, which they need to reach. It's not easy to move patients away from those number goals, but that's part of the job, is to try to get patients away from those numbers, which is, for example, what I never suggest to a patient any number that they need to achieve. And if they are continue wanting to be at a number, I keep reinforcing the fact that this is not a number game. And we're always going to focus on the health benefits and how they feel and what their energy levels are and the things that they can do and the things that they have done now that they weren't able to do before. The fact that they've been able to discontinue certain medications, the fact that their A1C levels are now much better than they've ever been before. Those are the kind of goals that you want to have with your patient, and those are the kind of things you want to focus the conversation on, and try not to discuss weight and not to get back to these numbers. You want to move away from them. And so don't set weight loss numbers as goals of treatment because they're not really helpful.
Mm-hmm. And that's a fantastic segue. Sorry, I'm just mindful we're at time. Make it. Go ahead if you want to have a quick little chime in.
I was just going to say a quick tip to doing that, because I know this was really difficult for me for when I started my practice, is trying to get patients to move away from weight-based goals, is really asking them why they picked that number, what's going to be different about their life at that number, and then really kind of use that as the reason, their functional status, how they're feeling, because they've associated that number with feeling better or with something else positive in their life. So it's a way to kind of tease out what that actually is and separate it from the number itself.
Perfect. Well, that's a great thing to end on. And as I was going to say, it's a great segue to our meeting next week when we're going to talk with Sue Peterson about pharmacology and surgery, and the following week we're going to talk about behavioral interventions. For sometimes when patients do need more actual reduction in mass due to medical issues, how can we help them achieve that when it's not happening with what they can do with some of these other measures? So we'll look forward to connecting with everybody in a week and talk about that. In the meantime, for those of you where we weren't able to get to all of your comments, please consider joining the Timed Right community, because there's a really dynamic conversation going on there, and we can carry on with the conversation between this session and next session as well. Thank you so much, Arya. So we're delighted that for the Q&A session, in addition to Dr. Sharma and myself, we have Dr. Sean Wharton joining us. So Dr. Wharton has his doctorate in pharmacy and medicine. He is the medical director of the Wharton Medical Clinic, a community-based internal medicine, weight management, and diabetes clinic. He's an adjunct professor at McMaster University in Hamilton and York University in Toronto. And he also works as an internist at Women's College Hospital and the Hamilton Health Sciences Center. Dr. Wharton is a researcher and is qualified as a diplomate of the American Board of Obesity Medicine. So welcome, Sean. And we'll start off with Barbara, who was right off the bat, first thing, putting her question in at the start of the session, and is reflecting a little bit on some of the terminology, and looking for some insight in different ways that you can speak with patients about their medical condition and terminology that can be used. Perhaps Sean, do you want to tackle Barbara's question first?
Okay. Hi, Denise, and hello to the entire team. Can you just state the question over one more time? I was trying to look at it in the Q&A, which I'm on my cell phone. Can you state it again?
Sure. Yeah. So Barbara was commenting about the fact that the term obesity can carry stigma and bias, and that she perceives that some patients are offended by the term. So she's wondering about what medical term to use to explain that obesity is a chronic medical condition. And I think all of us would try to use the term obesity, but just right. Generally, how would you in patients where, how do we do that?
Yeah, this is a great question, and it brings me back to when I first set up my clinic, and I wrote a little book to be able to help patients to understand their elevated weight and the challenges of it. So my book is called Elevated Weight. It is not necessarily your fault. So using the terminology that they have a increase in weight, increased weight or elevated weight is oftentimes a way when you're speaking to patients, it comes off a lot better. So the word weight is much better when speaking to patients. Elevated or increased is very clear, and it's not a stigmatizing term. The word obesity is stigmatizing when it comes to speaking to patients, and it can present a challenge. So I understand the challenge there. But when it comes to using that terminology in terms of the title of the actual guidelines, or when we're doing research, when we're talking about this medical condition as a disease, we need to use the word obesity. It's just like in the 1960s, where if you were diagnosed with depression, it was a big challenge. Nobody wanted to be called that I have depression or I have the diagnosis. But eventually, when we understood the biology behind it, that there was neuroscience and serotonin and a number of other factors, that biology released us to be able to use the word depression, and people were able to be freed by saying that I have a disease and it's called depression. I would like treatment for it. The ability to call it something that is a disease state that's recognized by physicians allows for medical treatment and allows advocacy. It permits us to move forward. So the word obesity is a disease. It frees us to be able to understand the biology, the processes, and it allows us to advocate. So that's why we're using the word and the terminology, because it's the right word to use. And when we're speaking to patients, using the terminology elevated weight, increased weight is an appropriate terminology.
Mm-hmm. Super. Arya, do you have some perspectives on that too?
No, I think Sean summarized it quite well. I mean, I've not had a lot of objections from patients once you explain that you're talking about a medical condition, and before you've done the assessment and before you've done all the tests, you don't say that someone has obesity, right? So what I've experienced is that patients sometimes self-label themselves as having obesity, and then when you do a bunch of tests and you see that they're actually not in so bad shape and that they're actually pretty healthy, you might actually have to explain to them that they're just living in large bodies, and that based on the new definition, we would not consider them as having obesity. So this can go either way. But as Sean pointed out, I mean, this is the medical terminology, and this is it's also how you say it. There's no judgment. There shouldn't be any shame in it, and you just have to explain, what the word actually means.
Mm-hmm. Thanks. So Julius is curious about whether or not individuals could have abnormal adiposity and its related consequences with a BMI less than 25. And so I think this is really getting into this notion of the fact that different ethnicities do have different, BMI cutoffs, where we should start to raise the question about whether or not someone might have obesity. But have you seen many patients with obesity with a BMI less than 25?
Well, so I can. Okay. Go. Yeah, go ahead, Arya.
Well, as I mentioned, we certainly have much lower BMI cutoffs for people of Asian ethnicity. They seem to be much more susceptible. Even a couple of extra pounds, can make all the difference between having diabetes or not having diabetes, and that can happen at BMIs of 21 and 22. So you need to have a very high level of suspicion in these individuals. And what you can often see is, even just in a physical exam, what you'll often see is that there's a little belly. You have very skinny arms, skinny legs, and then there's a bit of a belly. And even that belly might be below the waist circumference cutoffs, but clearly there's visceral fat in there. And what you'll often see clinically, if these patients do manage to lose even just a couple of pounds, you'll see a dramatic improvement in their metabolic condition. Now, obviously, these patients are much less likely to have mechanical problems. These patients are much less likely to have any functional limitations. They might probably also not have a lot of the mental health issues, body image issues, etc. might not be a problem here. But you can certainly have a lot of the metabolic problems even at quite low BMIs that would benefit from weight loss.
Mm-hmm. And I think it just, one of the points I want to raise is one of the things we're emphasizing in the guidelines is that healthy lifestyles for everybody, irrespective of their BMI. So we really are encouraging healthy diets, activity, stress management, etc., good sleep for everybody. And so what we're getting into here is this notion of lipotoxic fat. So adipose cells located somewhere where we don't want them, in the pancreas or in the liver. And as Arya says, in some, you can find that happen at quite a lot lower BMI levels.
And I would like to, and I can actually add into this as well. As a Black Canadian, I think it's important for me to kind of give a little bit of a definition about this. I do talks to a number of Black physicians and Black groups, and what they need to know oftentimes is that African American women don't really run into metabolic diseases until they have a BMI greater than 32. And why is that? Because they put most of their weight in the peripheral area, in the thighs and within the hips. So where the weight is located does matter. When we take a look at specific ethnic groups, and it can vary amongst each group, but in general, South Asians and the indigenous groups and white males tend to put their energy and convert it into fat cells in the central areas, causing the metabolic problems. And so, of course, as weight goes higher and higher in African-American women and in white women past BMIs of 32, they start to put their energy not just into the peripheral, but into the central areas also. So metabolic diseases happen there. But it's really important, and we need to be able to help people to understand that, that oftentimes that their quote unquote elevated weight or that BMI status isn't them. They are what their blood sugars are, and they are whether they're healthy or whether they are not healthy. And this ends up freeing a lot of my when I'm doing the presentations to these different groups, because they feel very labeled and very judged, although they are healthy and they're moving. So I think we need to be able to demonstrate that to different groups at different times.
Mm-hmm. Thanks, Sean. So Cheryl has a couple questions. So she's wondering with regards to whether we should be eliminating EOS 0, and also with new obesity guidelines, is BMI still considered when determining qualification for bariatric surgery?
Yeah, I can take this one. So I've actually recently recommended that we drop to 0 because by definition, 0 means you're healthy, and if you're healthy, you don't have obesity. So I totally agree that we should probably, drop to stage 0. The Edmonton Obesity Staging System was developed before the new guidelines came out, so that's why it's still in there. But I totally agree. I think the EOS 0 stage is now obsolete.
Mm-hmm. And what about the qualifications for bariatric surgery, Sean?
So then this is one of my favorite parts of the guidelines, actually, is that we are still using BMI as a criteria for it. But really, there's a number of areas where we know that BMI is obviously not the most important thing to look at. We use BMI because it helps us for a cutoff. We know that when we're looking at bariatric surgery, it is an expensive option. There's only so many people that can actually have it. So using some degree of a criteria ends up helping us. But if we look in the UK, we know that South Asians at a lower BMI status have that central adiposity, again, we talked about. So they actually qualify for bariatric surgery with a BMI between 30 and 35. And here in Canada, what we decided to do was use the evidence, great level A evidence that states that if you have type 2 diabetes and a BMI between 30 to 35, you should be considered for bariatric surgery that is covered and funded by the government. So that is the recommendation there, is that we're looking more at the metabolic diseases, and that should be driving us to say whether bariatric surgery should or actually shouldn't happen, not just the BMI status.
Great, yeah, thanks, Sean. So Veronica has been very patient, and she has an interesting question that I might tackle around a patient with a BMI of 27, anxiety and severe low back pain. And what would we recommend as the diagnosis? And I think with that, there's a couple things as a family doctor that I would wonder. So one of my wonders with this would be, is that patient weight stable? You know, second thing I would wonder is, what is the ethnicity of this patient? You know, is this a patient who is from Southeast Asia? Thirdly, do I have any indication of any other metabolic disease going on? You know, do I have an elevated ALT? Do I have impaired fasting glucose? And also the age of the patient, you know, is probably also really relevant here. So generally speaking, then the other question is, does the excess adiposity contribute? Is it contributing to this person's back pain? And the answer to that would be, you know, maybe, but probably not. It very well could be discogenic or something else. So the real issue then is just more of a practical one around, is this a person in whom reduction of weight would improve their pain? Possibly not, actually. And so it gets into sort of those practical issues. Now, if the patient's been having severe low back pain and is gaining a lot of weight, then I would worry about it in the sense of perhaps this is an opportunity for some prevention and for trying to head things off of the past. So as Arya was highlighting in the 4M slide, you know, we're interested in looking at barriers to root causes as well as barriers. And I do think we could intervene with a lot of people a lot earlier if we see that they're not weight stable. So it's a little bit of more of a clinical answer to this question, but hopefully that's helpful, Veronica. Arya, do you have any other thoughts on that one?
No, I think you've outlined it quite correctly. I mean, just to comment on lower back pain. So lower back pain is actually one of those pains which generally doesn't really get better with weight loss. A lot of people think it does, but it doesn't. So again, you know, the anxiety could have other reasons. The lower back pain could have other reasons. Whether or not this patient actually, you know, is going to get a relief of their anxiety or their back pain with weight loss is not clear. And so, as you said, you know, I would look for other, other factors that may suggest that this patient actually has obesity.
So Wayne has a question here. So he is wondering about how one would approach a patient with significant physical limitations due to severe osteoarthritis, sleep apnea, and a BMI over 45, where they remain physically limited despite optimal treatment. So presumably that means that they're on CPAP and their pain is trying to be managed. What do you think about that, Sean? How would you start approaching that patient?
Yeah, and that's a good patient, right? And it's a tertiary level patient. And Arya's EOS staging system oftentimes will label that patient as the EOS stage 4, where their obesity and their elevated weight and that adipose tissue is causing such significant impairments that it's almost at a end stage level. But being at that level doesn't mean a lack of care. So what we know is that anyone with renal disease that is at an end stage renal disease, we give them as much care as possible, possibly more care than we do others. Now, we're not going to be able to get their kidneys back likely, but we are giving them a dialysis treatment, multiple other treatments. Same thing here. We need to give this patient as much treatment as possible, and living with obesity is a real condition, a real issue, and we have a chapter on it. So people who are living with obesity and deserve the care that is afforded to every other patient. Now, when it comes to the potential of treating this person's weight, certainly looking at bariatric surgery would be one of the most important things. Did the patient, I'm forgetting, Denise, did he state that the patient already had bariatric surgery?
No, and it's not clear from the story whether or not they're on pharmacologic therapy. And next week we will cover with Sue, you know, the options here for this case for pharmacologic therapy as well as surgical therapy, right, both of which would be considered here.
Yeah, this patient deserves all 3 pillars. So they deserve to have bariatric surgery. So that is an absolute gold standard must. If they haven't had it, then there should be a reason why. There should be a big reason why, because they really ought to have it. Pharmacotherapy, they should definitely have it. If there is an insurance problem or a challenge or an issue, we have to advocate for it. We have to get angry. if that they cannot afford it, and therefore our advocacy will end up helping this medication to be actually covered. And then psychological intervention is necessary, regardless of whether we can get this patient's weight down or we can't. The challenge of being at that weight and having those many comorbidities related to those related to the adiposity is going to cause can cause some psychological challenges. So psychological intervention is also necessary here. So that's what I would do for this patient.
Sure. And the one thing I do want to just put a plug is for the chapter. It's really a unique new chapter in the guidelines from our occupational therapy colleagues about that, how to support people living with severe obesity that's causing significant problems. And there's a lot of gems in that chapter. I've learned a lot from Mary Forehand and her colleagues. So I encourage people to have a look at that chapter. So Leslie has a question. And her question is about a question that might elicit whether or not a person has internalized weight bias. So Arya, how do you approach that in your clinic?
Well, there's not a specific question, but you can already notice in the language that patients use to describe their own issue and their own problem. So when a patient tells you, well, this is my fault, and you really, and they're blaming it on their own lack of willpower or their lack of control over food, and you can see in the conversation that the patients are basically blaming themselves for the condition and for the fact that they're sitting in your office. They might even apologize that they're there because, sometimes they feel like they're wasting your time. And we know that this is true for a lot of people because we do have surveys from Canada, from the ACTION study that shows that many people, see obesity as a health issue. They seldom reach out to health professionals for care because they feel that this is something that they've done to themselves, and therefore this is something that they need to solve on their own. And so from that kind of a conversation, it becomes quite obvious that you're dealing with someone who has internalized weight bias. And so I can't give you a specific question, but it's not really very hard to figure out whether somebody has those stereotypes. And I will tell you that most patients do. Because if you've gone through life with everybody blaming you for the condition and everybody telling you that there's a simple solution, and you've tried those solutions and they haven't worked for you, well, then you do end up feeling bad about yourself and feeling hopeless and feeling that this is really your problem to solve. And that's basically the definition of internalized weight bias.
Mm-hmm. Absolutely. Sean, you must encounter this a great deal as well in your clinic.
Yeah, absolutely. And I think you can hear it in the language where patients who have elevated weight that's significant, where it really is in an area where they need to start looking at an intervention that is beyond diet and exercise. So what I do is I tend to recognize that the internalized biases that I expect everybody to have it. They live in this world. This world comes down on people with elevated weight. There's no if they didn't have it, it would be a surprise. So I ask my patients, I say, is it okay if we talk about treatment options above and beyond diet and exercise? And that gets them away from not having to delve deep into their internalized bias and them coming down on themselves. I've immediately told them that I want to talk about real interventions, real treatment options above and beyond their diet and exercise, which to me tells me that if they have if your age is the same as your BMI, you're 45 and your BMI is 45, you're 50 and your BMI is 50. That means you've tried weight management many, many, many times. And we're now in a position, if you're still saying diet and exercise, you have internalized the bias, and you now need to be released of that and move straight into treatment options. And that's how I try to do it. Can we talk about treatment options above and beyond diet and exercise that can really help with this medical challenge?
Mm-hmm. So Carfu has a great question where she says, often I discuss weight goals with my patients and use weight as one of the success factors. On the other hand, they're learning that weight should not be set as a treatment goal. So having a dilemma and how should I go about it? And maybe I'll tackle that one. Carfu, we've done some extensive work, and on Appendix 2 of the guidelines, there's a QR code where you can scan to get to some of the tools and resources that we recommend for tools in primary care initial assessments. And the key element there is a function-based goal. So something for the person that really matters to them. So what is the thing that would be different in their life? you know, perhaps a patient will say to you, well, I'll be able to play with my grandchildren, or I'll be able to go to the zoo with my grandkids and walk around the zoo without having to sit down. So different kinds of functional goals. One of my patients said once, I want to be able to walk up a mountain with my kids. So those are functional goals, and it's really amazing when people achieve those goals. And it's much more meaningful than saying, well, great, I did 152 minutes of exercise last week, therefore I met my goal. Remember, we can control our behaviors. We can't control what our body does with them. We can't decide that our weight is going to necessarily change. So putting our goals in the realm of things that we actually can control are things that are much more meaningful and achievable for people. So you get away from some of that therapeutic nihilism that comes when weights plateau as they do, and thinking that nothing I'm doing is making a difference. We'll see all sorts of improvements in metabolic factors and lots of other clinically important outcomes as well. But saying that your A1C is better is not nearly as meaningful for a person as saying, you know what, I was able to go out to the zoo and walk with my grandkids and I didn't have to sit down once. So I think that's my 2 cents on that from a primary care perspective. From the tertiary angle, Arya, Sean, thoughts on that?
Yeah, I can comment on weight. So one of the key reasons why you don't set a weight goal is because I have no way of predicting whether a patient can achieve a goal. So the dilemma that you have is, let's say, you know, you put out a number there and say, you know, you need this patient to lose 20 pounds, and then you make a dietary recommendation, and you know, give the patient an exercise plan, whatever, and the patient does all of those things and only loses 12 pounds. Now what do you do? Now you're nowhere close to the 20. How do you get to the 20? Well, you know, the patient is already doing everything they possibly can. And so you've just created a problem by putting a number out there that was not realistic for this patient, because I don't know what the number is for any patient. It depends on their age, it depends on the metabolism, it depends on how many diets they've been on before. Everybody responds differently. The defense mechanisms that bodies have to defend against weight loss are very, very different from one person to the next. So I have no way of predicting the amount of weight loss that anybody would get with any given activity. And so you don't set a weight goal. A lot of patients, and I agree, in clinical practice, this is a huge challenge because patients all have weight goals. They all have a number in their head that they want to be at. Sometimes that number, you know, they just make up the number, or it's a number that they were at some earlier point in their life, you know, where they felt better about themselves. Sometimes actually, you know, we've contributed to that because, you know, if you take the patient who's heard from their orthopedic surgeon that they need to lose 60 pounds. So these are all made up numbers, right? I mean, these numbers are not realistic. We cannot guarantee that anybody is going to achieve any kind of number. And as Denise already said, numbers are not behaviors. You want to focus on things that patients can do as a goal of treatment. And losing weight is not a behavior. Losing weight is something that may or may not happen when you change the behavior. So I try to move all my patients away from the goal. In fact, you know, I specifically never try to discuss weight with my patients at all. If my patient wants to talk about weight, I don't want to talk about weight. When patients lose weight, I don't respond. It's not, I don't congratulate them for the weight loss. I'm completely poker face. If they gain weight, again, I don't care. I want to talk about what they're actually doing. And those are the goals. So like Denise said, I want to talk about behaviors and I want to talk about things that patients can do. And I want to have what is often called non-scale victories. So I want to see the A1Cs get better. I want to see them have more energy. I want them to feel better about themselves. Those are goals of treatment. Weight loss is not a goal.
Mm-hmm. Awesome. So I'm just mindful that we're at time, and it's been, again, a fulsome discussion. Wayne has a quick question around level of evidence for the current recommendations. We were thrilled actually with the amazing amount of high quality evidence that's actually there and coming out more and more. So certainly each of the chapters has a level of evidence. There's really a great deal of clarity in the guideline themselves. So definitely have a look. We're thrilled about the progress that's being made in the field. I think I can speak with everyone with that. So thanks everybody. Next week we have Sue Peterson, who's going to talk about therapy. So She's going to talk about medications and surgery. So we're really looking forward to that. And I just want to thank all the team at Obesity Canada and the Office of Lifelong Learning for all their efforts on putting this on, and for all of you for making time for these webinars and for wanting to push the needle to improve care for patients. And thanks also to Sean and Arya for coming out tonight and supporting us all with a great Q&A.